Disassociation.
Oxyhemoglobin.
Yeah.
Disassociation.
Got it. Now I've got it.
Okay. So pretty much what this means, you have an XY axis, right? Okay. So when we're dealing with this chart, I wonder if I can pull up a better one. I can draw, probably not.
Because your hard and fast skills are so great.
No, I just don't think it's worth me dropping that page.
I feel that.
So down here, you're gonna have okay. And then over here, so your base axis, we are going to consider negative or +4 and negative. So this helps. This correlates to this, but this, your base axis correlates to your oxyhemoglobin disassociation curve. However, this is not shown on here because this is what you get from lab values. This right here, your B base axis, okay? So your normal curve, call it green, it's going to be something like this. There's not that. Maybe I should put it on the thing. Okay. So then, just bear with me. Give you representation. Okay. So obviously our green would be normal. Red. So you're going to have this. So obviously you're not going to walk around with a graph in your pocket. It's just not logical. You do kind of. But when we're dealing with this, we have to remember our base axis is being represented of what is going on this graph. Okay? So a couple things to remember. With our PA, let's go ahead and move. With our PaO2, what do we measure? Amount of oxygen on what side? Arterial, right? But you also have a PaVO2, which is on the side, or PbO2, okay? So your PaO2 you're seeing these readings, right? So on the arterial, the PaO2, roughly 100%. Remember, this has a direct correlation with your FPO2 minus a point or two. Okay? So these things, PaO2 is always going to be higher, but they're going to be within 1 to 2 points. So we can assume at the worst, this is going to be 98%, right? That's on the arterial side. It's a normal correlation, okay? You could, in theory, say this would also be 100. It's not going to be, but it's always going to be a point or two. So we could use 99 if you want, but there's a direct correlation between those two numbers. You're not going to have a PaO2 of 100 and an SpO2 of 70. That's not going to happen. Okay, but then on the venous side, we also have a PaO2, right?
That would be a PV of.
What do we think a normal parameter for the venous side is after we've had capital exchange? Anybody know?
80.
What are the numbers?
I don't know what you think you're gonna tell you. You're gonna say 100, 350.
Same thing.
That's 60 to 80%. I don't know what you said.
The venous side?
Yeah.
40 to 60. Okay, but this is where you're going to have the disassociation. On the venous side, why?
It's starting the oxygen.
Correct. But you're still going to have free radical SpO2. So this is where you'll see something like 50%. And then your SpO2 on the venous side would be 75%. Because why?
Hey, it's so bad.
Because this is where the oxygen is already offloaded from the hemoglobin. It's went to where it needs to go. It's picked up the trash. And your 75% is going to be your available supply within the concentration, right? So when you're dealing with that, the biggest thing to remember is the difference between the SpO2 on the venous side to the arterial side is always going to be 23. Okay. So on the green graph, okay. So if I have a patient that arterial SpO2 is 90, what is their venous SpO2? 67. 90 minus 23. So it's going to be 67. If their SpO2 is 80, what is their venous side? So that's what the difference is going to be.
Are you getting 23?
That's just a given number. Arterial SpO2 and venous SpO2.
That's just the standard. Like,
So now we're going to get into understand what happens in this left and right shift on the board. So your left shift, what do we think we're going to see when we have this retention of SpO2? What type of thing?
we would have we'd have a higher arterial. So, I don't know how big the difference is.
I guess what is a sign? Just trying to figure out. What is a parameter that we check vitally that would indicate this left shift? Think about an environment that we may be in which our body, that something we try to facilitate, thoughts. What do we try to do? We do passive cooling, right? Because we try to decrease the body temperature, right? So we do passive cooling. because we're going to have an increase of acids in the body, right? And we try to cool them down. So on this left side of the shift, you're going to see several things. This left side on the right, you're going to see a decrease in temp. You're going to see a decrease in your free radical hydrogen. And why would that be? Because when we get cold, what does our body do? It starts to shunt, right? When your body starts, you start lacking that peripheral perfusion, right? Because your body starts to shunt. So we need to keep this to our core. So your body tries to keep all of this oxygen through a molecule or a parameter called, this is extremely important, called 2,3-DPG. Okay, and we'll go over that separately here in a minute. But with this left-sided shift, you're also going to see a decrease in what else? You're going to see a decrease in all of those things. Okay? Now, on a right-sided shift, what else do you think we might see? Good job. An increase in an increase in hydrogen, an increase in CO, and an increase to 3-DPG. Now, what is 2,3-DPG? Anybody know?
What Chico for unlimited ammo?
So what 2,3-DPG is a molecule that sits on the red blood cell itself, or the hemoglobin part of the red blood cell, that helps facilitate the offloading of oxygen, right? So the more 2,3-DPG you have, the easier it is for those oxygens to debind from the hemoglobin to be delivered to where it needs to be, right? It's a 2,3-DPG is a molecule that is on the red blood cell that helps facilitate the offloading of O2 on the hemoglobin. So where is this, and where do we typically see something like this? Anybody know? Okay, where would we see the abuse of this?
Is it like when the athletes would get higher red blood cells?
In blood doping. So if you've ever heard the term blood doping, this is what they're doing. They're actually infusing their body with more 2,3-DPG because it allows the offloading of oxygen in their body to be more, which means their retention, we were talking about that 104.6, to increase, right? Because you have more free radical oxygen in the bloodstream, which makes it more apparent for those red blood cells to absorb oxygen, and they start blood doping, increasing their internal oxygen levels. So what does that do for them? It keeps them out of anaerobic respiration, cellular respiration.
Would testosterone do the same thing because it increases your hemoglobin?
It doesn't increase the availability of oxygen.
I need to give you some of that DPG.
Yes, 2,3-DPG. So why is this important? Because it keeps the body out of that anaerobic respiration. So these runners, these cyclists, a lot of these sports athletes that blood dope, this is why they do it. Because if we can stay out of anaerobic respirations, what does that mean? We create less lactic acid, less hydrogen buildup, more oxygen reserves, more oxygen bioavailability within the body, and less fatigue. So that is the whole point of it, right? So 2,3-DPG is normally occurring molecule in your body, and it is necessary for the release of oxygen from the red blood cells. But depending on what we've got going on here, whether we're gonna have this left or right shift is going to be what availability of oxygen do we have? And what do we think comes into play from a parameter that we can see with point of care testing or lab values? Thank you, your base excess. So most people don't understand what base excess means, and that's fine because unless you understand it, you don't want to attempt to control it, right? But when you have a left shift, you're going to see a base excess that'll be greater than plus 4. But when you have a right shift, you're going to see a value that is less than negative 4. So to understand what's going on, you don't need to carry around a picture of this graph. You can know if I'm between these values of norm, I have a normal oxyhemoglobin disassociation curve. What do I mean by normal? That means going back to this little chart right here, right? If I go to 40, like I said, this may not be close. If I go to 40, that's pretty well close. We should be around that 75 area, right? That's just how the graph works. And then if I go to 100% over here, we should be at this, be over here. We're going to be at around this 98 mark on the graph, right? And that's going to be normal. And that's where you can use these things here to say that's where this number comes into play, is this is always 23. Where you start getting disassociation is when you have this left or right shift. And that's because of your base axis. Your base axis is measured off of what? It has to do with pH, yeah. Huh? But what is bicarbon what? Because what is giving our osmosis value? And your excess is going to be measuring how much excess of this do we have. So if we have a negative value, that means we're what? And if we have a positive value, that means we're what? Now, if you ever have a shift, you would hope your patient has a right shift. And to remember that, just think right is right for the patient. Okay? If you have to force someone, or your treatment is going to force someone left or right on this shift because of your treatment, right is right. Okay? And right is right for the patient if they are compensating for metabolic acidosis through their breathing. Okay? But if we end up forcing someone, we'd rather force someone into this right shift than this left. These people on the left very rarely survive.
Is that what ended up killing, like, when COVID was getting bad, is that what was killing them?
That's part of it. Most of it was just alveolar collapse and schools.
And why were they using that? Huh? Why were they using that?
For
Two of the Park County officers that died in Pearl.
it's just part of confusion because their lungs weren't working.
It was a surfactant lung problem, it wasn't a blood gas.
So there's a direct correlation, get into in a little bit, between surfactant and availability of oxygen. Okay? Yes.
Sorry, the question. So
Hold that thought, so I'll forget.
why would we want to shoot for a right-sided shift? Because I'm thinking, why would I want to drive their temperature and hydrogen counts up in their field? Fix, it has to be
So if you increase this, we're obviously going to be increasing what? On our plan settings for what we're doing, what are we going to be increasing? And what directly binds to free radical oxygen? And what does that create? Water, or what is hydrogen and oxygen create? And you get what in the tube? So we can expel that free radical oxygen. The problem is, that if you create this too much, you just created
Oh, that shift causes nitrogen washout.
can't. Because we start retaining all that oxygen, pushing all that nitrogen out, which is going to then create what? Alveolar what? Collapse. That's why I say these patients very rarely survive. Okay? So,
Left shift can make them suffocate.
so, yeah. It's more, at that point, it's more of a perfusion issue. You've created a nasty incubus. That is very difficult. So does this make sense to everybody?
But I think that was happening in the patient you where when we were suctioning, we were getting blood and the nerve in the alveoli. Why would they not switch to more of a room air type to keep the nitrogen in there as opposed to upping the oxygen? Where if you have the oxygen in there, that's causing the collapse.
Okay. You created this, or it's happened. Okay. So we've got to the point where we force the nitrogen in, right? Or let's just say there's still some nitrogen in there, but our alveoli are rupturing or collapsing, causing this flow, right? Where does our gas exchange happen? So they're rupturing, collapsing. Does the amount of concentrated O2 at that point, you have to have pressure to keep them open. So just doing passive oxygenation is, again, it's going to saturate the free availability of the O2, but it's not going to allow gas exchange. That's the two things. Just because the O2 is available doesn't mean it's perfusing. That is the biggest thing. So just saying here's a bunch of O2 passively, that doesn't mean you're having that gas exchange. So that, again, once you get here, these people very rarely make it. So with that left shift, again, you're going to have that base excess of +4 or high. You're going to, so on the left shift, you have something called the haldane, Haldane. So with that, you have the effect of oxygen on CO2, okay? The effect of oxygen on CO2 and hydrogen binding to the hemoglobin. So again, that's when that hemoglobin has a much higher affinity for hemoglobin than oxygen, right? So if we are driving that hydrogen down, that means the hydrogen is going to bind easier to what? Because it's trying to retain itself, because we see those levels coming down, so it's going to say, we need to keep what we have. Okay? So when you have that, your O2 is going to bind with the hemoglobin, and it's going to cause a allosteric interaction, which causes the release of CO2 and hydrogen. Now, if you don't understand that, that's fine. You don't need to. If you want to look more into the Haldane effect for your own guilty pleasure, feel free. Which causes the release of CO2. So what that means, and again, this is not something you need to know. It's just something that can help you understand. So the effect in layman's terms, what this means is that once one hydrogen binds to the red blood cell, the hemoglobin, it makes it, and the allosteric effect, what that means is once one person sits down, it's easier for the other three to sit down. Because that reaction has already occurred. So what it's saying is once one hydrogen gets on that red blood cell, it starts kicking oxygen off of it and starts accumulating with the hydrogen. And that's what the allosteric makes it easier to sit at the table, okay? What this causes is a huge increase in free radical oxygen in the blood because none of the oxygen is attached to what? The hemoglobin. That's all saturated with hydrogen, right? So you're going to get a bunch of free radical oxygen. You're going to see a lot of differences between here. So we said normally 23, right? In a left shift, what color did I use for left? A left shift, you're going to start seeing 10 to 15. Okay. The narrower that is, the more dangerous that it is. The confusing part about this is with this Haldane effect and with this left shift, it makes it significantly easier for the lungs to pick up oxygen. Because why? We're dumping all that hydrogen, right? But then they'll immediately bind back to it. We just continually increase our O2 free radical ability with the bloodstream. So what's happening here? Going back to remember, right there, 2,3-DPG, what's happening in a pathophase here is you have something called citrate. Where do we typically see citrate in the medical field? Anybody know? Mag and what? Nope. It is a binder for blood. So blood products is where you'll see this accumulation of citrates, right? Now, citrates are important because that citrate will pretty much, now remember, let's step back a little bit. What does 2,3-DPG do?
It helps.
Drops the oxygen.
One at a time, so we know it's on the
Helps you
side.
offloading.
It allows oxygen to be released where it needs to be, right? It allows it to break off the red blood cell and go to where it needs to be. What citrate does is it encapsulates, if you will, that 2,3-DPG, and there becomes a disassociation between the body, free radical O2, the tissue that says, I need O2. Because what are we reading? The body's saying, I have a shit ton of oxygen. But where is it all? It's free radical. It's not. What's on the hemoglobin? Hydrogen. So it's free radical. So are we able to deliver that oxygen? So that's what it's doing, is it's encapsulating that 2,3-DPG, not allowing it to bind and release where it needs to be.
That's bad. And why is it doing it?
What?
So if the citrate encapsulates that molecule, that's bad, right?
Not beneficial, yes,
So why is it doing it?
because that's a byproduct of citrate. Like, if we're giving packed red blood cells, okay, we're trying to retain what? O2. Hemoglobin volume and O2. That's just a byproduct of it. Now, that eventually breaks down. But the problem is immediately you can see those huge disassociations between free radical and availability of oxygen. But it's not allowed. Because again, if we're giving blood, what do we have? We have if somebody's getting blood, they have a hypovolemic issue, right? So its whole goal is to say, not releasing this, but keeping this for the main ship. You know what I'm saying? We need this. Come here. So we don't want to just offload wherever we need. So its whole goal is to say, conserve as much as we can, use the least amount as we can.
It's just conserving it, keep making it to where it's not used.
It's not being able to deliver wherever it needs because it's retaining so much. So since it's retaining so much, You're just not getting the delivery to the tissue that you need. Now, the problem is with a hypovolemic issue, that's necessary with a doc. Because you won't be getting blood, oxygen to the brain and the heart and all the necessary areas. We'll be dropping off at the toes and the knees and the fingers and the nose, right? So that's its whole goal, is to make it bioavailability for the important parts. The problem is it's difficult for it to discern what tissue it needs to deliver to. Does that make sense?
Yeah, that was gonna be my question, like, how does it differ between where it's dropping off? Or is it just like, there's the addition of it, keeping it, eventually it'll drop off?
Yes.
Is that just pressure, like pressure heart versus pressure in the nose?
No, because your tissue is what's saying we need oxygen. So what can we do from our side to prevent this or help this? It's a simple problem. Think about cardiac arrest after we get drugs.
Horrible.
Calcium. Hey, look, give me the wrong answer, so my
Or we give calcium chloride. Calcium chloride is your antidote, your only saving grace for left shift.
And
Calcium chloride, if you have a higher base excess factor, so you start getting +8, +9, +10, plus whatever, calcium is your friend.
Let's just put it into
Sure, you're in class.
Yeah, I'm here, I'm learning. If we do experience a high phase excess and we have a patient who is not doing great, is that enough to just say, okay, yeah, we're gonna go and give calcium even?
For me,
Yeah.
absolutely.
Okay, cool.
But you have to denote that there is a VQ mismatch here. We can't just say perfusing good, end tidal's good, FPO2 is good, pH is good, calcium. No, you have to identify my end tidal is high, my perfusion is low, I have a VQ mismatch, and I also have a shit base excess. Calcium is my friend.
Okay, cool. So I had +20 not too long ago.
All.
Cool, gotcha.
I'm glad I now know what that means.
Does it say it on the life staff?
What
Yeah.
is the calcium doing? Because what I thought that was for the cardiac muscle itself to help that.
So it's helping contractility though, but the calcium chloride is neutralizing that citrate. It's allowing that, it's allowing the 2,3-DPG to work.
On Friday for life, can we do that too?
Absolutely.
One of us.
I can, if we have to, I'll order a box of them and we'll do ISTATs and everybody, so you can all schedule.
I drink Wilson thing, guys. I'm fine.
Three, DPG not allowing it to bind.
Not allowing it to release. 2,3-DPG helps facilitate the release of oxygen. And the citrates that force it to keep it. So, yes.
What if the potassium's also dog shit? Would you still give them calcium or not?
If the potassium is not, how much?
Just asking, what's your base level if you're like, okay, this is too low, I'm gonna withhold this calcium?
No.
Dog shit low or high?
Well, I would be fine, wouldn't that help? That. But if it's dog shit low, yeah, what's your cutoff there?
I'm still getting it.
No matter?
Huh?
No matter? Hey, I'm here.
Isn't it easier to correct the potassium problem?
Potassium should solve itself once you start getting muscle release and moving and your sodium potassium pump goes into play. You should start releasing more because you got to think. So sodium potassium pump is normal muscle, right? And what we're doing at that point is we're retaining all the potassium because we don't have delivery of oxygen to this muscle tissue. So once we start having oxygen delivery, what's going to start allowing that coefficient to happen? You'll have a release of potassium. Should. Yes, ma'am.
I know we have chloride on the truck, but calcium gluconate,
Same concept.
same thing but different?
The gluconate breaks down.
Cause this reminds me of like when Dr. Hicks was like, coconate, if
Yeah.
you remember that.
He took the dude's head because he wouldn't listen.
Yeah. I think that's the situation.
You and I were partners.
Yeah, I'm pretty
You
sure
really
that,
took it all off the truck.
no, we never had coconate.
Is there a way to correct a left shift easily?
How calcium works. And fix your BQ mismatch.
So that's just, if you have a left shift, you just pray. You're pushing everything and praying that it doesn't shift.
Yep, and you obviously have a BQ mismatch here.
Mhm.
You're right and left shift, you definitely have BQ mismatch. Okay, so does everybody understand left? Now let's go to right. So on your right-sided shift, you're going to see an increase in your temperature, your hydrogen, and all that stuff like we've discussed. Okay? Your right shift is again, is when you're gonna see, I know Jackie said she's seen some that said -2. I use -4. So anything on -4, so -5 and on, is going to warrant or denote a right-sided shift. So how the left-sided shift has something called the Haldane effect, your right-sided shift has something called the Bohr effect, BOHR. Your Bohr effect is when hemoglobin O2 binding's affinity is inversely related to both the acidity and the CO2 concentration. So what does that mean in layman's terms? You have a reduced affinity to O2. That's layman's terms. So you're going to have a lot of CO filling the seats on these hemoglobin and a lot of hydrogen as well. It wants to offload oxygen because there's a lot of consumption. Again, think about from a movement standpoint, being athletic and exerting muscle movement. Think of running. Running is the simplest example. When you run, what's your body need more of? Oxygen, right? So it just wants to sit here and dump as much oxygen off as it can in all these places because it says we need oxygen everywhere to keep these muscles going, to keep the heart going, to get, and not only that, but to pick up the waste that we're getting from the hydrogen and the CO2 to bring it back to the lungs to breathe off, right? So it has lower affinity, so it breaks it, it gets it off easier. So the 2,3-DPG is highly active here because now it's dumping all of the shit off, saying we need this availability of oxygen wherever we can in our body. Does that make sense?
So it's the carbon dioxide, right? It's not carbon monoxide.
It's picking up CO and CO2. It wants to offload that O2. You're going to have a much wider. You're going to have a narrowing difference, right? So on your left side, on your right sided, you're going to have widening ones, or it's going to be somewhere in that 27. Okay. Now, why is this? Why would we see these wider variances? If my SpO2 is 98, we're going to use 35. What does that make my SpO2 down here? Why do I have less venous return? SaO2.
Dropped off.
Because we're using more. Muscles are using more. Our body is using more of it. We're exerting force, we need more oxygen, right? Just like if I try to run to the health department from here, I will make it to the hospital parking lot, and then I will get picked up and taken for a ride because I don't run, right? My body's not going to be used to that. So once we start offloading, that's where that blood doping comes in because my body's not accustomed to doing that. So when I blood dope, if I sat here and just injected myself with 2,3-DPG, I'll fucking run to the health department and run back. Now, afterwards, I'm gonna be dead because I'm gonna have all that lactic acid buildup and stuff. But again, that's what blood doping does. Gives you that 2,3-DPG to sit here and just continually offload this oxygen as we bring it in. So you can see a raised PaO2 into the 200s and the 300s. Because again, what is PaO2 measured? partial pressure of that arterial O2, right? Since we're just continually offloading it, we can see these huge elevated levels of this, okay? Where are you typically gonna see this, do you think? What type of patients would you see this right side? Think about what's going on with the hydrogen, think of what's going on with the temperature. Sepsis is the biggest patient population medically that you'll see this right-sided shift in. You can also see it in cocaine use, meth use, MDMA use, anything that's going to raise your body's temperature, increase your heart rate, or things like that. Thyroid storm is a big one, or just some type of metabolic acidosis going on, which, you know, it's pretty much sepsis going on in the body. Those are where you're going to see it.
Go over when you would see the left-sided shift. Examples.
The left-sided shift are typically going to be drownings, hypothermic patients, respiratory failure patients, especially with drug use, things like that. Now, if I tell you this, would it be better? All right, some boards, it's my left side. Would it be better to have or which patient would I rather have?
I think I'm all for it.
Why? Take the right and left out. Let's think, I mean, I've already told you right is right for the patient, right? But why?
Because, left side, they're probably, the SpO2 is probably just a this read rather than.
That's a bunch of hydrogen.
From your PaO2 than it is on your.
Perfect. So what are we having here? So I would 10 days of the week, I'd rather have this patient. Why? Because this patient is going to have an SvO2 of around 85. This patient is going to have an SvO2 of about 50. And what does that mean? What's that mean to us? This is trying to do gas exchange and dump oxygen. This dude just fucking retained. Make sense? This person's body is trying to do things. We have a huge gap here that says, I came in with this much oxygen, I've released this much, I still have body system function within the body that we're trying to correct. Now, can we correct that with some invasive ventilation? Absolutely. But what's happening here? If I invasively ventilate this patient, am I helping?
No.
No, because we already have this. This is damn near perfect. This is the problem. And can we correct that with pressurized ventilation? No. Can we correct this with pressurized ventilation? Yes. This is why this is important. This is why medication is a must. Yes. Because we have to do something to neutralize this to start releasing this.
Is that when you give the calcium?
Here?
Yeah.
Yes. Again, you still have to make sure you've got this good. You can't just look, every patient that has a base excess of +8 in the calcium. No. No, not how this works. But if we're dealing with left shift, we can't, osmomechanically ventilating anybody is not going to help them because they're not having that disassociation. They're retaining all the oxygen. That 2,3-DPG is not allowing it to release. So why am I going to force more oxygen into them when my problem is the 2,3-DPG? So I bring this to 100. What does that make worse? Now I'm at 90. I have a 10% exchange. Invasive mechanical ventilation is not going to help us here. Here, we have a 42% exchange. All I need to do is bump this number up. Can I control that? 100%. Very difficult to control this mismatch. And these are the people that you'll see, like I said, they'll just start going into multi-system organ. Kidneys can't keep up, liver can't keep up, lungs can't keep up. It's just, you become alkalosis and just fucking good. Anything that I can clarify on any of this? We understand 2,3-DPG. We understand nitrogen washout. We understand why that's happening. We understand our baseline coefficients here for differences.
Let me take more picture before you raise it. Okay. Brain.
All right. Now getting into
Can we take a quick, like, 5 minutes on my brain?
it's just 2,3-DPG and oxygenation hemoglobin disassociation.
I can't even say that. Let's say that. I think my brain needs some fresh oxygen for a minute. Yeah, just more of the, I need a blood dope.
All right, take 5.
Almost get all in, it's too much for them.
After having one, I think I missed part of it. And,
Speak up, Mr.
yeah, what am I missing, the actual mismatch? So I understand the basic, that's no issue. I'm worried about the mismatch, what's it called?
VQ mismatch?
VQ mismatch. I think I'm missing that.
Okay, so we have to understand that the whole premise of this is to make there's not a VQ mismatch or there is a VQ mismatch. Okay, so what we're saying is here is V is ventilation, right?
Ventilation diffusion mismatch.
Correct.
Got it.
Is you have to make sure that this can be solved through other ways. We have to make sure that the VQ mismatch is in our doing, and that we're having a good ventilation diffusion ratio.
So if I'm sitting with my patient, I got the cat refill still, I'm still getting positive signs, and I'm still getting some positive, still seeing those obvious signs of perfusion, obvious signs of, you know,
Point of care testing is going to help you verify your SaO2 less. But like I said, there is a directly correlating factor between SaO2 and SpO2. It's just little picture, big picture, right? But making sure that your SpO2 is good, making sure that your hydrogen and your base excess aren't off, and all of those. Not, you have to address your base excess because of that mismatch. Because you might have having proper ventilation is everything we're going to see on the vent. Having proper perfusion is a whole different ballgame.
Yeah. Yeah.
And that's done through point of care or through final.
So what I'm saying here, is we went through, okay, what happens in our VQ when our circuit?
I guess my question, I just gave you the scenario here. The patient's heart rate's 140. Are we going to give calcium? No, because our perfusion is the problem.
Yeah.
The heart rate is the problem. We need to address the heart rate to do something with it. Now, is that because there's a hypovolemic issue? Do we need to do fluids? Do we need to do something there? Why is our so the ventilations aren't the problem. The perfusion because of the cardiogenic shock is the problem.
So we worked through the cardiogenic side before, and now we work through the pH side.
Mhm.
So that's the two main components we're looking at. We're making sure one,
You have to make sure there is not a VQ mismatch.
I just said, I missed that.
Your doctor will tell you when you have to be through this match.
So fucking money by you, man. Please.
Oh,
Where does
I
that?
know.
and RT will let you know too.
Yeah, or do, be like, hey, we're gonna.
Well, we know how much it is.
Cool, I'll charge.
Where's the 2, 3 GB?
Sorry.
It's naturally occurring.
To increase it, help increase. How.
You just getting in.
Nothing that we can.
You gonna afford that?
Again, the only way to control that is through injections and such that will allow that to happen, but that's where you'll get that long doping. Or not long doping, 2, 3 GP blood. So there's nothing we can do. We can only change the bioavailability.
I don't know, he wants to scrub and order whatever.
He said that they are going to try and figure out if they can provide me a check.
Yeah, y'all have a good one.
I know they thought so.
Friday, I may or may not get that.
They're going to go my 12-hour class day for the thing for my,
You didn't pay for any.
so they only 24 hours. Because they're taking patrol and nothing in the bird.
They best be writing me a check unless Scott Boston wants to see my condition, then I'll check.
No, not all the payroll companies, it's too late. I'm like, well, I texted you literally 10 minutes after you said. Did you read from that? So far, it's just mine, and everybody else is checking their account. Justin had 40 hours of overtime and was barely $3,000.
A new chapel, please hold on.
You know, fuck it up.
I have a question. I think my front could. If they even really are, man. I lost an air tag again. I can't find it. But I know it's here on the property. So. Oh, yeah. Well,
Can't you find it?
The air.
Yeah, tell me about it there.
my-
That's the whole point of an air test.
Listen, I was just curious before I went on scavenger hunt.
Give me your phone, I'll do it
We're
for you.
gonna have to do it every. All right. All right, anything that I can clarify, oxyhemoglobin disassociation curve.
When I can pronounce it, I'm sure I'll have questions.
What is it?
Oxy. It's.
We're hot, probably not appropriate, but it is very hilarious. You probably appreciate it.
Anything else I can clarify for anybody that what we just went over? Everybody's good, we can test right now.
Can you guard up? That's my friend. Where'd you go?
So, does the ISAT show all these values we're learning?
Most. I gave you 4 levels of it.
I can obviously barely do. I figured out I was doing wrong. Division, and then I could immediately go to the
Yeah,
division.
Ken does, Bob.
So,
Very slow.
Hemoglobins,
Okay,
oxygen,
okay,
binding,
Okay.
affinity
okay.
is inversely
Exactly. For the B.
within a vision,
Oh. Yeah, okay.
related
Okay.
to the acidity CO2 concentration. You want layman's terms? you will have reduced affinity to O2.
Killing me, bud.
Hydrogen and CO2.
Better you jump fast.
You're my spirit.
It's hard.
I wake up every day and I'm like, I need more today.
All right, we're gonna get into actual mechanical ventilation. We are talking about vents. You can move my shit if you wanna sit, there's a seat one over here, there's 2 seats up here if you wanna come grab it. So this is going to be math heavy, this is going to be numbers heavy, and this is going to be. It's gonna be heavy. First, we're gonna hit with a couple definitions. First one is anatomical dead space. Anatomical dead space is the amount of space that does not contribute to alveolar gas exchange. So what would that be?
Alveolar.
Gas exchange. Okay, go ahead, watch TikTok.
Or TikTok.
Where, so what does that mean? Where is that air? It's in our trachea, it's in our mouth, it's in our nasopharynx, it's in our bronchial, it's still in the airway path, but it's not causing gas exchange. So that is number 1, anatomic dead space. How do we calculate anatomic dead space?
This, title?
Hmm?
Total mass title?
Alveolar volume first. You can, or to figure it out, pretty much what anatomical dead space is 1 ml times the patient's weight in pounds. So if you have a 200-pound patient, you have 200 ml of anatomical dead space. You have a 136-pound patient, you have 136 ml of anatomical dead space. Super simple. Just remember, this is one reading that will be in pounds. You can probably do that.
I'm not, okay.
So please know, this is one of several big keys that you need to remember. Tidal volume for mechanically ventilated patients is based off of ideal, not their actual body weight. Ideal body weight, not actual body weight. So what does that mean? That means 2-year-old. So, and this, I'm not, Lucas, how tall are you?
6 foot.
Okay, anybody else in here 6 foot? Okay, Travis, Denny, and Lucas are the same height. And this is not being shitty to anybody, they're obviously different sizes. However, since they are both 6 feet tall, they would receive the same amount of ventilated tidal volume. It has nothing to do with how small, how medium, how big, how whatever your body shape is. It's based off of that height and its ideal body weight for that type. Now, the reason that's difficult is because for everybody is somebody, Gage, how tall are you? 5 what? 8. Okay. He's 5'8", I'm 5'11", depending on the gas station that I walk into, okay? Gage is going to have a significantly larger amount of body mass than I am. Doesn't mean he weighs more, but his body mass is more than mine. He's a bulk fellow, right? But again, he, bigger than me, is going to receive less tidal volume than I am. Does that make sense? Has nothing to do with size. I'll pass these out. This is something that we use here and we keep them in our trucks. This is ideal body weight for intubated and initiated tidal volume center. What do you learn?
With you,
They're in the truck. Tape on the thing.
we're the one, Nick, who does truck checks.
Or where the vent is.
that door where the vent is, it's taped on there. So is this based on BMI?
No, it's based on height.
Yeah, the best
We're
one.
getting this.
I'm not on here. To be fair, that's why I don't. I'm not on here.
What if you have two children?
I'll have to ride. Use that.
Who does not have one?
I pray out of the way.
So,
Price not on here.
Right. Then you don't get paid.
So fucking nerd.
Look, the single.
For Shauna.
14 ml for every inch. So just go.
you can, so at that point, you figure 12 ml per each inch. So if you have to subtract 6 ml for 6 inches, you're gonna subtract what? 72 ml. Make sense?
Does that apply for peds too?
PEDS, no, PEDS has its own formula. So. We have to consider something called, your VEs, or minute volume. Okay, VE is minute volume. And how do we get minute volume? Correct. Respiratory rate. Respiratory rate. Respiratory rate times tidal volume. Okay, this will give us our minute volume. Now, normal for this is going to be somewhere between 4 liters and 8 liters per minute. And why do we say that's normal? Because it's going to be dependent on your height. What I receive and what Dylan receives is going to be 2 different parameters. He's 8 inches taller than I am. And again, it's going off of his height, not his weight. Okay? So that's number 1. So adults, 4 to 8. So this is adults. Pediatrics, for 1 year to 14 years, is also 4 liters to 8. Okay? Usually on the lower end, but that's what it is. Now, here's where it really comes into play. Pediatric, which is 0 years, 1 year, is going to be 0.2 liters per E per minute. So pretty much anybody younger than a year gets that, everybody else should be 4 to 8. Easy to remember. So, now, earlier, Corn brought up a good point. You have your minute volume, you have your tidal volumes, but you have something called an AVE. Anybody know what that is? You have something called alveolar ventilation. Why is that important? Where does gas exchange happen? What is important here? Ventilations to perfusions. So how do we think that we would obtain our alveolar ventilations? Anybody have an idea? Your tidal volume minus your dead space is going to be your alveolar ventilation. So again, we'll take me, 5'11". Okay, so get on your chart. I can tell you, I am not a hypotensive patient. I'm hypertensive, if anything. So we have, find me on the chart. Where is I? 452. 452. Okay, now I weigh 235 pounds. So do the math.
What's you with?
235 pounds. $217 and alveolar. So my tidal volume was what? 452. Now, this is where patient's body weight comes into play. Okay? So I'm going to put both of you on the spot. So I'll call you 6 foot.
I thought the desk, it was one, one ml per pound. You weigh 235? Okay, that was going, that's what, there's no. That's a compliment, okay?
All right. Anyways, you're 6 foot. So what's 6 foot on the chart? For what? 466. How much you weigh, Travis? 200 pounds. 466. Who else is 6 foot in here? How much do you weigh? 175. Who else is 6 foot in here? How much you weigh? 8. Okay. So now let's do these. This one here is obviously going to be easy at 266. This one here is going to be what? 281. Okay.
You came across. Yes, JK.
So this is the same. This is 3 different patients, right? And look at how our alveolar tidal volume changes.
Take a run, or they might have a pathetic route.
This is where it becomes important, okay? Because we have to understand our alveolar tidal or our alveolar ventilation is going to be important here, right? So this is where we can start adjusting. What's the first thing that you think that we might have to adjust if we don't want to adjust tidal volume, right? Because we have how many trucks are in
We're all here, buddy.
possibly it's gonna be this side of 135 and be independent. They wanted us to go to Campbellsburg. Holy shit. No. Hold on. Northwest side of.
I fucking.
Okay. So what is the first thing that, hey, What's the first thing? We don't wanna adjust tidal volume because we have properties in place that say we have properties in place that say we wanna go off of ideal body weight. But if we're potentially having a BQ mismatch, what's the first thing that we might want to adjust? So I've heard respiratory rate. What else? Somebody just said, what?
A minute.
No, because that's dependent off of that. And then those are correlating factors. So time between, so also known as the IE ratio, which we'll get into. And what else? Here's the big one, the really fucking easy one.
Yeah.
How crazy. Contrary to popular belief, not everyone gets 100% FiO2. Why? Again, nitrogen washout. We have to be concerned with that. We have to look at the parameters in place of what the patient's reading. So typically, we're gonna start somewhere around that 40 to 50 range is where we wanna start, right? And then we'll gauge off of perfusion and our VQ mismatch out there. Not everybody starts at 100% FiO2. You can kill people that way. You'll throw them into that left-sided shift, you'll set off their base axis, hydrogen retention will come into play, and you'll make that person alkaline very quickly, okay? So these are the two things that we should start with. First, very easy, doesn't do anything, doesn't change anything as far as total VTE. As soon as we change this for this, what are we changing? Our minute volume. Right? So before we change minute volume, we want to try to keep that in the correct parameters of that threshold. Okay? So again, I went on a little soapbox earlier of volume versus pressure. Pressure is superior in 99% of the ways. Okay? I got 99 problems with pressure ain't. That is how it's going to be. Okay? So we have to consider something called compliance volume loss when we're dealing with mechanical ventilation. And is it super important on anyone above a year old? No, it's negligible and it's indifferent. Okay? But what the volume breath is going to be is 2 ml times your peak inspiratory pressure, your PIP. And this is something that is called compliance volume loss. Now, what does that mean?
Would that be potentially like, whenever your lungs have gotten real sticky from the tobacco and it's not able to completely fully inflate?
No. So this has to do with the circuit itself. So everybody, who in here has not seen a patient on the vent? Everybody's seen a patient on the vent? So what happens when, so we have a ventilator at rest, right? And then it spools up and it delivers that breath. What happens to the circuit itself? It moves and it pressurizes and it causes all of that plastic tubing to expand. So what compliance volume loss is, when that pressure hits that tube, right, it's causing all of those ridges to expand. That's the volume compliance loss. But again, if I'm receiving a minute volume of, we'll call it 8,000, right, and let's say my PIP, my peak inspiratory pressure is 20, what is my compliance volume loss? 40. And what is 8,000 minus 40? Is there a big difference between 7,960 and 8,000? No. So again, it's negligible, but you have to understand, this is not important in adults. It is highly important in pediatrics. Because of this, if I have a pediatric patient that, how much Braxton weigh yesterday? 30 pounds? 30 pounds. So my daughter is 30 pounds. How many keys is that? Divided by 2 is 15, minus 10% is going to be 13.5, so we'll call her 14 keys, right? So, going off of this formula right here, what is my minute volume? Huh? 2.8 liters. So that's 2,800 ml, right? 2,800 ml. So 7960 over 8,000 equals what? Let me do that math for you.
0.995.
So 0.995, meaning I reach 99.5% of my volume delivered. I'd say that's pretty fucking good. But let's do this. What's 2760 divided by 2,800?
0.98.
0.985. So now this doesn't seem like much, right? But what are we not including? The dead space. So we've already lost 1.5% here, minus our dead space. We're going to end up somewhere with a 60% efficiency rate here. Where here we'll be in the 75% plus.
Where did you get the 2760?
2,800 minus
Where are the big numbers coming from? Thousand and then. Oh, huge number, okay, that makes sense.
So again, this only matters when you're dealing with pediatric patients. And honestly, 30 pounds is a bit heavy. Your peds patients will be somewhere around that 10 to 12 keys at most, right? You're usually dealing with those 4, 5, 6, 7, 8 pounds or 8 key patients. So, going back to pressure versus volume, when we're dealing with pressure breaths, compliance is not a factor. Okay? The loss in accordance to like the compliance volume, it's not a factor because the PIP, the pressure, is already factored that in because what's happening, again, when the breath gets pushed in, that oxygen tubing is expanding, right? And where are we measuring PIP at? Our peak inspiratory pressure. Where are we measuring that? In the airway at the flow sensor, right? And the flow sensor so this is our vent tubing, right? This attaches to the vent. She is the vent, right? The flow sensor is at the most distal part of the tubing. Where does compliance happen? All through here, right? So when we're dealing with pressure, does anything that happens before here matter? No, because it's measuring here. So the compliance loss is negligible when you're dealing with pressure ventilators because that pressure loss is before the flow sensor. And the flow sensor is where we're measuring. So that means it's measuring from here to the lungs. Anything that happens beyond here, unless there is a leak, is negligible. Doesn't matter, it's already factored in. Okay? So that's why, again, pressure is superior, in my opinion. Now, not to say that there's not need for volume, because in certain places there is, but most there's not.
So it's a volume ventilator, do you have to adjust to compensate for that?
Yes. Now, here, no, because again, it's 40 ml. Pediatric patient, 100%. So, let's go over some normal vent settings. So you have two types of patients. You have injury patients. That's number one. You have lung protective patients. There are only two groups of people in the lung protective group. That is going to be asthma and COPD patients. Everyone else is considered an injury patient. Whilst they may not be stabbed, they are still considered an injury patient. So, your ideal minute volume for your lung protective patients is going to be 4 to 6 liters, or 4,000 to 6,000 ml for your lung protective patients. 4,000 to 6,000 ml, or 4 to 6 liters on your lung protective patients. 6,000 being your max BTE.
That's a minute.
Can help if I write this down?
Yes.
So you have injury patients, and then you have lung protective patients. These are going to be 4,000, 6,000 tidal minute volume. Okay? These are going to be COPD and asthma only. These are the two types of patients. Injury is not these people. So whether there's an injury that you think of, I just want to stab Casey, whilst that's an injury, it doesn't equate that it has to be an actual injury for them to be not lung protective patients. Now our goal on injury patients is going to be 6,000 to 8,000 ml BTEs.
What if you like have a patient and you don't know,
Respectfully, how would you not?
like if you find an unresponsive patient, nobody's around, nobody's like. What do you do?
So if someone falls from a tree and nobody knows who they are, they don't have a history, we treat off the bite. My rule of thumb, me, pretty decent at airway, I start with an achievable VTE of this. Because it's the lower end of one, it's the beginning of another. It's a safe round for both. Now, you're probably asking, how do I decide whether I do 6, 7, 8,000 or anything in between? Astute question. We take our ideal body weight and we find our correlating minute or tidal volume for that. Right? And then we multiply it by either 6 or 8 ml. So let me get into this. So what we're saying here is if I have we'll call it when we're dealing with pressure, if I have a ideal body weight of call it 160 kilos, right? What is 6 times 160? Okay. Now, to me, that's and then what I'm trying to show you is here is that would mean that I need BTE. Where is that on here? Exponentially high. But you have to make sure. Now, you step back. This is all dependent on what? Anybody know? What is part of my BTE? What do I use for my BTE?
Minute volume and respiration rate.
Do we have anything set here? So we can't do this until we have a weight. Okay, so how do we pick our rate? We have two types. How do we pick our lung protected patient rate? Everyone starts at 10. When you're lung protected patients, everyone starts at 10, not to exceed 14. Now, there's always going to be extenuating circumstances for that, but we have to be mindful that they're lung protected patients. Right? Now, considering what lung protected patients are, do we think rate is a problem here? What are lung protected patients? Asthma and COPD. What is COPD? By definition, chronic obstructive pulmonary disease. It's in the name. That is the name. Okay? So chronic pulmonary obstructive disease means what? What does that mean? Their pulmonaries are obstructed. Thank you. Chronically. And it's also a disease. They have damaged alveoli or reduced surfactant. Now, going back to what Gage said. So, surfactant is key into this VQ problem that we have. So, you have, that's a long, okay? This is not a long, they don't sound long. So, you have this surfactant here, right? You have surfactant, it's a wet, it's moist, okay? Now, on the level that we're talking about surfactant in, we're not talking about the extracellulars. We're talking about these bundles of grapes that are called what? Alveoli. And between those bundles of grapes, there's surfactant itself between the capillary bed and the alveoli. That's the surfactant that we're concerned about. Okay? Because the surfactant actually creates a permeable channel for the gas exchange to happen. Okay, so we are dependent on that surfactant for that gas exchange to happen. So going back to what you said, in a lot of these COPD patients and back to COVID, which was a big one, what did we see in regards to surfactant? Low to nil surfactant. Which meant what for us? That's a huge VQ mismatch because of our perfusion. We're not having that gas exchange. Again, these were the patients that we were seeing okay SpO2s in because we're getting the oxygen in, but we're not getting the carbon dioxide or the hydrogen out, right? So we're seeing those huge abnormalities to SpO2 versus end-tidal versus your your SCO2s and things like that. Yeah. Well, it sounds like a bubble. I know that there's spam. So we have to have that surfactant for on the alveolar level like this, right? You have the surfactant, right? And then in there, we've got our capillary beds at that alveolar level. We don't have that surfactant, that gas doesn't happen. So again, that is going back to what we were seeing with a lot of these COVID patients is we were trying to pack them full. Nobody knew better at the time. Everybody got in the room and was like, this ain't working, we'll try this. Fucking sure, why not, right? That's what COVID was for the first 6 to 8 months. Just, what's it gonna hurt? In Austin terms, it works, don't it? We don't know, but might as well try it, because we can't break anything anymore. So that's what we were doing for the first several months of COVID was just trial and error. So, once we started doing that, we realized oxygenation wasn't the issue. What was our issue during COVID?
Oxygen.
But what did we finally realize during COVID? We had to control more than FiO2. PEEP being the big, because without the surfactant, what was happening to our alveoli? It would just collapse. We start getting this widespread atelectasis. That's why we did these chest x-rays, they called it that whiteout. All of that was just dead tissue, dying tissue, or obstructed tissue. They weren't full of air. They were just collapsed, so it caused that whiteout on the screen. So what I'm gonna tell you, and this will be a test question further on here later, is our normal peak is, we start anywhere from 5 to 10, depending on who you are. 5 to 10 is where we start, right? For these COVID patients, we were immediately going to our max. Immediately. Because and what is PEEP? What does PEEP do?
Keeps them open.
Keeps your alveoli open and your lungs open. How, what's the downside to increased PEEP? You have increased pressure, where said that, which can cause two things. Not only can it cause breath stacking, but it can also cause CO2 retention. Because what we're doing is it's harder for the patient to exhale, right? Exhaling is supposed to be what type of process? A passive process. But if I'm constantly holding my hand to Justin's mouth, is it passive anymore? No, it takes effort to blow that out. That's why if you ever see those COVID patients, you'd see them being burped every now and then because they'd have to push on their chest. We were doing that when we were doing flights or when we were doing ground transports, that halfway through we would have to break that PEEP. We'd have to break the tube, push on their chest because it was so exhaled that we'd have to set it back and start this process all over again. Because we were just starting getting to the point where the PEEP was holding and these values were getting high. Now, going back to what we were talking about, our rates start at 10 for our lung protected patients, right? So when we're talking about non-protected patients or injury patients, when we're talking about injury protected patients, we can do one of two things. We can use this chart, but if you don't have this chart, there's an easy way to do it. To get their VTEs. The easy way to do it is, and you can do this math, bud, follow with me, okay?
Follow.
All right. So we take a patient's weight in kilos. So let's say we have 176 key patients. No, 176 pound patient, my fault. How many kilograms is that? 80 keys, right? So what we do, if we don't have this fancy chart or you don't want to use it, the easy thing for all non-lung protective patients, so all our injury patients, is we do 100 ml times their weight. So what does that make this patient's VTEs? 8,000. Pretty simple process, right? Now, how do we get our respiratory rate? We still need one more thing. We need what? We need our VT. We got our VTE, which is our minute volume. But we want to break this down into VTs. So what do we do? Don't do that. I mean, you can, but here's a cheater. You take your patient's weight again, which is going to be 80, right? We multiply it. Remember, we wanted 6 ml to 8 ml, right? Per breath, right? So we take this patient's weight, and again, I start low, so I'm going to multiply it by 6 ml.
Look like I got 3 hits.
Now what do we do?
Divide it.
By what? We want to take our BTE, which is our total minute volume, and divide it by our tidal.
Or it's like 16.6666.
16.6 is what you get here, right? Now, let me show you why I love math. Let's say this was a 70-pound patient, or 70 kilogram patient. So what do? 100 times 70 equals what? 7,000 ml BTE. To get our BT, we're going to do what?
70 times
70 times 6, which is going to equal what? What is 7,000 divided by 420? Point what? This will always equal 16.6. So what does that mean? Our initial respiratory rate is always 16. So on all non-lung protected patients, the rate is 16. On all lung protected patients, we start at 10, go to 12, max of 14. Now, why is this important? Where does our rate come into play in vent theory? Does anybody know? You said the answer, I think it was you. I mean, that matters, but your I to E time. What does that stand for? Okay. So what that is saying is we are going to take. Can I erase all this? Anybody want a picture before I do? My throat's so. I'm sorry if I can say it. Thank you for your time. I'm doing most of this part by myself.
First time together, there in Jello.
I'm telling you, like that really shooting.
I was gonna sing for you.
That's the best play.
Yeah.
All right. So going back to 16 is our rate for what? Who?
Protected patients.
Injuries patients. And what's our rate for lung protected?
That's
14. We always start at 10, 12 with a max of 14. Now, our rate is important because of this. Now, these are all starting points. Patients are going to react differently, okay? But these are starting points. Now, this is why it's important. One thing we're not going to get into today, but we will, and we need to remember. I know I went over this term a couple weeks ago, is IVR, inverse ventilation ratio. Okay. Now, you can do nasty damage and literally kill people with IVR, but sometimes it's needed. Because our normal IE time, so IE we've established is what? Our normal IE time is 1 to 2. But what does that mean? Wrong. So what we do is we take how many seconds, okay, what are we measuring here? Right, 16 what? So in a minute, there's how many seconds? We divide this by 16 here, right? So what does that equal? 3.36?
0.27.
So 3.27? Is that what you said?
It's 3.7.
Okay, 3.75. Okay? So what does this mean for us? What does this equal? So then we take 3.75 divided divided by 3. What does that mean?
1.25.
So now with this IE, that means my inspiratory time is 1.25 seconds. And my exhalation time is what? 2.5. Now, going back to these lung protected. What am I doing? I'm taking 60 and dividing it by what?
10.
And we get 6, right? Again, going back to this IE ratio, that means 6 divided by 3 is what?
2.
So that means my inspiratory time is 2 seconds, and my exhalation time is what?
1.
That's where this comes into play. It is not over 1 second and 2 seconds. It's over a minute dependent on the rate. Now, before we can get ourselves into trouble, a lot of people, my people, your people, all the people, usually set this ventilation rate relatively high. We'll see these people that are doing 20, 22 breaths a minute because they have an elevated N type, right? And what are we going to do? Hyperventilate. No. The problem with this, right, is now let's say we took this rate to 24, right? Respiratory rate. What's 60 divided by 24? 2.5? So what's 2.5 divided by 3? 0.83. That means my inspiration phase is less than a second, and my exhalation phase is barely a second and a half. Is that allowing time for gas exchange? No shot. Okay? Now, understanding this IE time is important because sometimes we, again, if we're having lower end-tidal CO2, right? But again, going to that metabolic process, we might see a low respiratory rate and a low end-tidal, right? What can we do to fix that? Inverse ventilation ratio. What do you have inverse?
You have a longer inspiratory time than you do.
You have a longer inspiratory time than we do an expiratory time. So we'll start inversing these numbers, where our IE will be 3 to 1. Because we're blowing off all of that, right? We want to start retaining some of that CO2. We want to give it time for that oxygen to allow that gas exchange, right? It's not that we want to retain CO2. It's that we want to allow time for gas exchange. And when does gas exchange happen? Upon what? So we need to give that a longer time. But we have to be careful with ventilatory rate. So going back to our 16, we have already established that it's 3.75, right? But what do we do now? What do we divide this by?
4.
4. So what's 3.75 divided by 4? 0.93. 0.94. You round it. Okay? So, at a rate of here, how many seconds in is that?
2.82 technically.
Okay? And then, obviously, so here is where we're going to have to start dropping that respiratory rate down if we're going to do an inverse. Okay? Because if not, we're going to start stacking here. And with stacking, we can cause lung expansion, barotrauma, all of that stuff. So if we are going to do an inverse vent ratio, we need to bring that rate down. And we're typically going to do it in these patients anyway. Very rarely are we going to be doing it in a non-COPD, non-asthma patients. And by COPD, that's not just that's COVID, that's all of those lung disorders, right? Some type of chronic pulmonary disease. Okay? So we're already going to bring that rate. So going off of that, we have determined that it's 2 seconds, so that means it would be 6 to 2, right? That's what we're going to see with our CO or lung protected patients, right? Okay. So, that's where, but again, you have to be careful with your inverse fractures because you can cause extreme barotrauma, breath stacking. You can cause a sympathetic nervous system response because you're going to be increasing potentially what? If we're doing a 3-second inhalation time versus a 1-second exhalation time, what are we continually increasing? Interthoracic pressure. And interthoracic pressure is going to put pressure also on what? Okay, so you have to watch for that sympathetic response to make sure you don't have a bradycardic or tachycardic response. It's extremely important you watch all your vitals if you're going to IVF. So we've established how to get our VTEs and our tidal volume at our 6 liters to 8 liters per key, right? Our goal, again, 6 to 8 ml per kilogram, 4 to 6 ml. Again, typically for both these patients, I start with 6 if I have to remember one. So 6 is kind of a standard rule of thumb, unless I can tell that these patients are really struggling and volume is not my issue, pressure is my issue, and I know they have COPD, I'll drop that down to 5 or 4. Good. All right. So again, 6 is easy rule of thumb, and again, that's what we're going to try to achieve to do. So anything that I can clarify on that for you? It's pretty straightforward. It's just remembering the process. Vent theory can be confusing as fuck. One thing I did tell you, adult is 1 to 2, pediatrics is 1 to 3. Standard time.
So the standard IVR is gonna be a 3 to 1.
2 to 1 standard, but you can go 5 to 1 if you want. It just depends on what you've got going on. And please remember, you can do 5 to 2, you can go 4 to 2, but that's gonna be 2 to 1, so it just really depends. Okay? Yeah, you can go 3 to 1, 4 to 3, it just really depends on what time. Now, again, that is all rate dependent. Because I can't give you, this is what I'm gonna show you. I can give you an IE of 1 to 6 with a respiratory rate 22. Why? You can, right? But this is going to be nil. Because we're going to take 60 and divide it by 20. We'll just do 20. Math and get 3. What's 3 divided by 7? Like 475 or some shit? 428. So that means my breath in is 0.428 and my exhalation is 2.5. Why are we doing that, right? So we have to understand that you can't have these widespread IEs super wide, okay? Closer to 3, but please understand rate, time, and all that stuff go in. So a couple of terms that we need to know. So we, again, going back to so those of you that have Zoll and those of you that have Zoll, you're dealing with something that is called P-plat. What that is, does anybody know what P-flat stands for?
Peak plateau.
Uh, so, and we all know what P is, right? So when we're dealing with volume in ventilators, like your Sols or your Ravel, you're going to see different waveforms that are gonna look like this. And what we're doing, we are watching what your P flat is measuring this. Right? So you can see that this waveform goes past your plateau at times. Now, I'm not saying you won't ever get a normal like this. I'm not saying that will never happen, but it's rare. Because what it's doing here is it's saying, you have told this machine, I want 500 ml per breath, right? That's what it's saying. So what it is doing, now you're gonna set P flat limits. And this will never exceed your P flat limit. So you'll say my P flat limit is, that's the max on P flat limit, it's 30, okay? What it's doing is it's saying, during this IE time, right, it's saying, here it's 500 ml. It's going to push it in until it hits that P flat, or the peak limit, and then it's gonna find that plateau of how much pressure can it hold to get that 500 in, right? So it's getting 500 in, this is the lowest pressure I can do at this time to continue to force this 500 in, and then I'm exhaling. That is what your P flat is. It is measuring your peak plateau pressure to maintain that delivered volume. Okay. Now, this is why it can be that, is because if you have COPD or you have some type of obstruction, I'm going to hit my P flat real quick. Because if I have already a bunch of pressure, right, and I want to deliver a bunch of volume, it's just two fists colliding. I've got resistance and I need pressure, we're going to peak out real quick. So that's why volume, in my opinion, is subpar at times. So when we deal with pressure breaths, we typically use a mode called PSIM-B+. This is pressure simulated volume. Okay? So we're using pressure to deliver a volume, but not exceeding that pressure. So when we're dealing with P flat, 30 is our max. Okay? What do we think we're using when we're dealing with pressure volume? Anybody know? So instead of using a P flat, we're using something called a PIP, or a peak pressure. Okay? Now, I don't want to say those terms are synonymous, but they mean the same thing depending on whether you use a pressure or volume bit. You're not going to be wrong if you misspeak and say my P flat is whatever. Now, your peak inspiratory pressure on pressure vents is going to be okay, a little bit different, a little bit higher. Why is that, do you think? Anybody know?
I would assume that it doesn't, adjust down for that plateau.
What it's saying is, I'm going to deliver, so let's say my vent setting. My BTs are 50, 5. my initial pressures, my initial vent settings. What it's saying is, all right, I'm going to break this all down like we did. And we're gonna say, we're going to break this over 60 seconds to get my, 3.75. Break that down, so my inspiratory is going to be every 1.25, and my expiratory is gonna be every 2.5, right? So what it's saying is, during this time, it is going to get, in that inspiratory phase, over a second and a half, it's going to get as close or slightly past that tidal volume as it can without maxing out that pressure. So if I have no resistance, you might see 520, 525 tidal volumes on it because there's not a whole lot of resistance, right? So it's saying, I'm going to take this pressure, and I know that this pressure is safe, and I'm going to go to the most suitable pressure or most suitable tidal volume without maxing out that pressure, as close to this set limit as I can. Now, it doesn't stop at 450, but you might get 480, 460, 470, 440, 430. There's going to be a varying degree there, but you have to still take into consideration the pathophysiology of the patient. This is where it becomes safe. If I have Emily on the bench and she is on a volume delivery, and as that volume starts to give, she coughs. What happens? It's still going to deliver that volume. It's going to push through that cough until it plateaus, until it hits that plat, right? What happens on a pressure event if she coughs? It's going to hit this pressure, stop, and she might get a tidal volume of 160. Shuts off. What does that prevent? What else? Why else is this beneficial? Because you might have patients that are still taking their own breaths. And what does PSYNV here do? It takes this rate and calculates the patient's breaths, subtracts it from here, and will deliver the difference. So if I have a patient that's breathing 4 times a minute, the vent's only going to deliver 12 mechanical breaths because it's taking into account the 4 breaths a minute that that patient's doing. So instead of having 20 as a respiratory rate, we're still going to have 16. So it's a much smarter vent. Now, you do have the Rebel, amazing vent. It's volume breath. I love that vent. That is the one vent I will say, volume breath. It can equate for some of those things as well. But pressure makes it just easier in my opinion. Any questions about any of this?
With the big assembly, is that, I guess is that in this instance, they're say like, say you want to wean them off and then eventually allow them to still breathe their own breath, not fighting against you. We'll get that to.
And that's why, that's the mode that we're in 95% of the time. You know, whether we have a resuscitated arrest or an intubated patient, we're not gonna catch everything immediately. And I'm not the type of provider that just immediately sedates just for the fact of sedating. So there's gonna be times that the patient becomes arousable in the back of the truck and might take that breath or two. And then it's gonna take you a minute to get that sedative and stuff ready. It's not fucking them up for 3 or 4 minutes to where they're struggling. I'm sure any of you that have those AHP vents, those big boombox ones, have seen patients put on that. They're normal, they're comfortable, they're fine on that hospital bed. And as soon as you switch into that AHP, they're grabbing. Because the pressure is so much different that it's just saying, fucking take it. Right? Regardless of what happens, you get this much pressure all of the times. That's what that vent says. And those people like, don't like this. That's why you'll see those patients fight that vent. So vent settings are really, really important. But PSYNV is good because again, like you're saying, you know, if you're in the back of the truck and you're in the PSYNV and the patient takes it, you don't catch it right away, or you want them, you know, you don't want to snow them until we get to U of L, be like, you can evaluate them in 3 to 7 hours. Like, that's not the type of person I want to be either. So you might have that person where they're not suffering, they're not struggling, but they're still taking that ataxic breath every now and then. Perfect. Because you can get 2 other things that we need to go over real quick. Take a break. Is these 2 numbers. CStat and RITS. Anybody know what those mean? CStat is static compliance. Somebody tell me what that means. No, CStat. You're correct on the RITS. Okay. What's static compliance, somebody? If you don't know, look it up. Get involved. 4 people here.
It represents pulmonary compliance at the given fixed volume with no airflow or relaxation.
So how do you think we get that? By that definition, what does that mean?
It's a measure of the air during their inspiratory thoughts.
Pause. So not inhalation, not exhalation. So based off my vent settings, how do you think I get that?
Pressure.
What it is, how we get this, is going to be our tidal volume divided by PIP minus P, or P flat minus P, 1 and 2. So, giving you the vent values I've given you over here, what is my CSAT score for this patient? I've used PIP here, P here. So my PIP is what? Minus 7 is what? 18? Yeah. 18.
Divide
So
50 by
450 divided by 15 is what? 25. So here's the problem. You need to treat your patient, not your vent. But for ARDS patients, let's make sure it's your normal CSAT for ARDS, for your lung protected patients, is going to be 30 to 45. Normal, 40 to 60. Now, with that being said, you need to treat your patient, not the victim. But your static compliance should be somewhere around those measurements. You said this one was what? Now, your RIX is your inspiratory resistance. Normal value for your patient on this is going to be 10 to 15 millimeters of mercury. Unless we're dealing with COPD patients, then what do we think it's going to be? Lower or higher? High. Why? Because they have problems with their alveoli. So those patients, you can see anything 15 to 30 millimeters of mercury on their inspiratory resistance. So that can help you, like Emily asked earlier, how do we ascertain if we don't have the history? If they have a high rinse off the rip and their everything else is checking out, it's a good probability that they have COPD or ARDS. If they have that high, or we have a dislodgement or an obstruction in the tube. Okay, that's something that we need to verify. Going back to peak pressures, 5 to 10 is a good starting hold from there.
For both patients.
Yes. 5 to 10 is a good starting. Your peak pressures always start around 25 with a max of 35. Like I said, you can adjust those pressures as needed. Those are just safety concerns.
Peak pressures?
Peak, the one that's 25, start around 25 with a max of 30. Your P flat started around 20 with a max of 30. If you're using a volume.
Except for the peak at 25.
What did you say for
Okay.
flat?
Pit is 25 with a max of 30. P flat is 20 with a max of 30. Now, one other thing that we need to consider is something called driving pressure. This is the most important threshold that we have to consider. How do you think we get our driving pressure? What do we think we do? Think about what we're doing and what those values over there represent. How do you think we get our driving pressure? Huh? Yes. We take our peak inspiratory pressure, or our PIP, we subtract our peak. So our driving pressure of this patient would be what? Solved for it earlier, 18. Our goal here is to be 15 or less. That is the goal for driving pressure. Because the higher that driving pressure, the more drastic there is a change in their lungs that can cause that barotrauma. Especially if your IE time is inverse or short. Because what's happening is they have this resting pressure, and then here's a bunch of pressure to push it in, and that big change can cause some barotrauma in the lungs, especially if they're breastfeeding. What you said the goal was? 15 or less. So what would I do here? Either increase my peak or bring both my levels down, right? I could bring my peak down to 5 and my peak down to 20 to achieve my 15. Or bring my peak up to 10, so then my driving pressure is 15. You have ways to do it. That is going to be patient dependent. I can't tell you always bring your peak down or peak up, or your peak down or your peak up. That is going to be patient dependent. Bye, Charlie. So, any questions about that? No?
What was the,
Huh?
what was the ideal?
Start at 25 with no greater than 30.
Yeah, I think for the case that they would want to keep it.
You're not necessarily wanting your PIP higher unless your peak is. You want to keep it. That was a bad example. That was just shit. So, like on a normal patient, this would be more realistic. So, on a normal patient, I can see this being. Leroy. I can see that being more accurate. So the last thing that we're going to go over before we break is you have to understand that on pressure vents you have a PIP, but then you have a peak PIP. Okay, so you have two peaks, two PIPs. One is saying I want this to achieve this tidal volume, but I'm also setting a hard limit not to exceed. So my PPIP on this monitor would be 40. And why is that? Because these are all your pressure events are cumulative pressure events. What does that mean? That means that you take the tip. Okay, so my true peak here is what? 30, right? But if I don't set this higher, do I have any variation to change that tidal volume delivery? So I always want to set that 10 points high to give that some threshold in case there's some resistance, some movement, some spasms, some cough, some something to deliver that tidal volume. Because if not, especially if I want to see how patients are trending, if I notice that I'm constantly getting high pressure alarms, I know that I have to adjust these because I'm hitting this threshold to deliver my tidal volume, right? So then I would know, all right, I have to increase these or I have to decrease these, especially if I'm getting high pressure alarms. And again, we're gonna go over this vent hands-on and I'll show you what I mean and this will make more sense. Okay? 5 minutes, 10 minutes, what do you want? Okay. Everybody good?
No,
What are you not good? You're not saying anything.
I'm trying to retain.
Take-
Yeah.
How do you know you don't know?
I have tried
So let me
it.
put it right. You know,
It's a process.
so we're having a. All right. Get all your show down and showing.
My husband's work.
Or basically. Clinical Tuesday. Sure. What got the training for the hospital?
Track by the.
Was it?
Yeah.
I thought I was gonna put it. I think one of
I think that.
This is something that you need.
You do.
In all the good ways.
Capstone, you can't drive past midnight for capstone.
Not here, no.
Oh,
Yeah, here.
Yeah,
yeah, they didn't allow 20.
okay. Yeah, like I said, I just need to get my hours, because the rest of this week I can't find it anywhere. And I know our
Yeah,
last
he
day,
came off the one over there.
the 19th. So I said, get, you don't have the one I need.
I'm ICU day Wednesday, I'm double for the.
What the hell you do show up here?
Your way out?
Problem is, I'm gonna go.
I mean, it's. It doesn't look like else, it's that you're gonna, what really you write about it. Okay. You can count, it, but the problem is. You can count it, but it's just gonna, it's still gonna be patient contact. Hours, that's 60 hours, and end up turning 90 to get your contact. And that one, no.
How you doing? Hey, Red. You look tired and exhausted.
So what is our holdup? Anything?
I think it's just, my brain's mixing up all the teeth, all the teeth.
That's pieces.
So your
Swinging from everybody.
peak and P flat are the same for your lung disease. Look what I have.
Say that again?
Your peak, hip, and P-flat.
Well, you're only gonna have P-flat on your volume delivery,
Right?
and your pivot will be on your pressure.
But you said people,
The
they're not
term,
technically.
the term people use interchangeably, but P-flat deals with volume, pivot deals with pressure,
So pip is the pressure response.
and P-flat is volume. Now, like on the Hamilton, you can do pressure or volume, so you can have P-flat and pivot on that, both on the same delivery. You'll have P-flat or pivot. They mean the same thing in ideology.
Number 502.
So in the hospital, are they using the pressure things?
Most of them, yes.
Did you get to hear about my spicy Clark County patient? So we used to run on her all the time on Bartle Mountain Road,
Had her the other day.
the 600 pounders. It's the one I was talking about with the exploded valve. Anyway, they come in and she says she's feeling like shit, pressure for like 80s over 60. PA lifts up her like 100-pound kid and sees that she has a colostomy, but she's never put a bag on it. Her solution is she wraps a towel around it, and every couple hours she brings it out into a bucket. So the PA was like, "Oh, that's gross." Pulls the towel over. Or it was people were still over.
That's good stuff.
Then the doctor was asked had me hold her leg with a straight cap. I don't think.
Listen, every time they go to catch somebody in the hospital, I go in heights.
I've been sweating. I just look at it on my foot. Whatever y'all need, I'm here.
They're doing extra work over there on it.
Don't make the same mistake I did and take your hourly rate times it by all your clinical hours. Really depressing.
You know that I have somebody on Bartle on road the other day.
We used to run it that all the time, because if the daughter would call 911, then literally an hour later, the mom would call them. We would legit be there every day of the week. Either that-
What's the phone? I was working. Yeah, it's great for folks.
This lady was going to put 600 pounds.
That's not the same one. I don't know, everything's running together
I'm that Floyd is fucking busy all the
Yeah.
time.
all the time
All the time.
with 40 molds in the
It's
yard.
crazy. And like people there, I thought Louisville was bad. Like this dude walked in and he got his back with that backward. Realized that he couldn't get right home, so he was like, "Got up here, walked back to the yard, and had a test pit, so he could go back and got his bed."
Oh, that's funny.
Even though he had no.
We took a drunk in there one day and
So I
they
think
kicked
this
him
is
out.
the population.
And they found him hiding behind the vending
on-
machine in the waiting room one day.
Floyd was very much like.
Check yes.
Even when they're like, let me straight cat someone, it's like I'm supposed to do that, I don't want to do that. Cause then I'm here for you. Sarah gloves out.
The agenda thing. Anybody learned anything today?
I don't know where you're getting. It's kind of awful. I don't know where you're getting.
Building Casey.
Correct. Period, contacts, all that stuff.
Oh, so this.
Oh, yeah.
On 60 divided by 60 to get each breath, each circular breath to be 3 pounds divided. So what we're saying is we have to divide, we take 2 plus. Taking the breath. Okay, it's not more fun. Dividing it by 3. Multiply.
Only legal.
Yeah, you've never seen it. Oh.
So if we did a 1 here, to 1 here. So we're gonna hit 3.75. Yep. There's no rule for this. 0.9. So that means it'd be what on the 1 side?
Wondering where you were getting this. That's us.
Okay. Yep. Everybody back? So who's learned something? Okay. So let's start here. Who wants a copy of? Please understand, these are my critical care notes, so there's gonna be some stuff in here that you're gonna be like, do not need, just. Period. Ascertain the stuff we went over, not all of the stuff in these notes. So I'll print. Some of these amongst each other. I'm not going to do this every time, because this took me a lot of time, a lot of studying to do, but I understand this is a very heavy topic. So. Yeah, print it for mine. How is it that these cheap ass printers have air drop fucking pretty capability, or fucking printers run?
Smile away, boys, smile away.
Alright, so everybody can go get their copy of it.
What printer that be?
They're front and back, so it should only be 3.
Nice cut.
Sorry. I don't fucking
He's
know.
having a fucking good time. All you promised, Taylor. Here's my note. I get 2 black out.
I think 4 pages long.
Clearly there's a page. So.
The last page will have like 2 sentences on it.
I didn't give you the little page. And I just don't get it.
You're not getting paid at all.
Thanks.
All this.
So, bring.
For what it's worth, we're only 15 weeks away. But
That makes me so good. They said, here's the penalty. Why would you flip it?
for what it's worth, 15 weeks. That's attainable.
Hey, my first medic class, we didn't turn on. Yeah. But it was 2012, so I don't know, if, like,
You fucked up.
Vince, were you and far between back then?
They pressed in around.
Apparently my cousin didn't want to go for this. You know Jeremy McKimball,
You all get your.
I like Larry.
and I'm still mad.
Science.
No, it's like, he yelled at the high schoolers because we ground transport.
They don't want to be the first.
So I'm still mad at him because he yelled at me because we ground transported a patient.
For hot, by the way.
Huh?
Hot.
Oh, it's not a big deal. He was right. The firefighter on my yet. Shaking me.
Oh,
We didn't know there was a helicopter coming. No one told us.
Dude, I'm about to walk in the. That thing is done.
Be next, Thursday. How you doing?
Go to the farm.
Go to sleep and not wake up. I think your interview went well. You're wearing the.
You feel fit and I'm in all
time?
No, I'm feel right.
You can't wear
I started this job like this.
You realize that I haven't seen you too much.
Oh, that's right.
Yeah.
We're riding together a lot.
Yeah.
Yeah, no, we're pretty good. So,
Meet Ryan.
I don't learn people's names until I see them. Well, actually, that's not true. Marcellus.
it's always after lunch.
Marcel. John or
Let the Marcelli door be.
So. Look at the park. Park.
I went with Ryan and Danny.
Danny sounds familiar.
Danny Jacobs and Ryan.
I've only done one shit.
Give me all.
I only had 4 6.
Mark, you tell me that.
He doesn't know how he's training.
Fight still go.
Yeah.
So. Whenever this is not.
Good, paid pretty good. They could be up every day to pick up shifts. Like I wasn't in this class, I'd be working 6 every day. I live in the working.
I don't know what he did. Evidently he pulled something a little too hard.
David Mullins.
Just because you can doesn't mean you should.
It's. You know who David.
If I asked, it's going to be like.
Ellie.
Got told that.
Yeah, you were.
That person. They are. Did I get it? His car. His car.
I know, does he work up like around where you live? Lunsford, JR, Lunsford?
He's up in Congress.
No, I don't know that name.
What county is that?
Like an hour and 45 minutes away.
Really?
Yeah.
He worked at Yellow for a while.
They flew someone from 10th and 6th.
Hey, that was his history.
Oh.
That's the only time that's ever been done. But it was done rightfully so, I mean. Backed up.
You know, I'm sure most people they think about
I've never seen.
I love it. I think the cool and stuff is all cool.
Years.
Superman. Fucking Superman. The one I know Friday is an EMT.
It's not very easy. It's 36 hour shifts in Facebook. It's
Sitting in the park, not.
Jack, can you put this back in the air?
Oh, he said something to do on Friday.
Oh, I mean, because he's always constant. He's more control.
Is anybody missing one?
We're not.
I'll take two.
Be
Oh, there's
fair.
one extra.
To be fair. You're fucking. Are we officially at the ESPN?
Before Friday.
Yes.
Oh, wow.
What? Yeah. Yeah.
Here to stand up.
Alright.
You see Neely's job. I see.
Alright, so. I know Nigel and Sterling said they don't have ventilators at their, anybody else? No. So this is a Hamilton T1. They're a critical care vent, they can do majority of what it can do. It can do non-invasive, meaning BiPAP, CPAP. Also do true BiPAP, true CPAP, also do your ASV, TSMV, so, as you can see, this is kind of a very unique setup here. You've got your feeder lines that go to your flow meter on the end, that's what these are. It's your flow meter. You have your exhaust port, underneath, and you have your two connections here, okay? We have the ability to connect SpO2 and CO2 readings in line if we want to. Just because it's all on the monitor, and we also have the ability to add humidified air. So when you turn hours on, everybody see, do I need to shut the light off while I don't? It takes a second to boot. Okay, so that tells me we have performed our self-test our function. This hasn't been turned on in a minute, so, all right. So as you can see, it's our home screen. It always starts in standby mode. See what I'm doing? So it says up here that it's in standby. Also tells me that there's loss of external power because I'm no longer plugged in. This has about, I think, a 2.5 to 3 hour battery life. The outlet with constant running time. These here will port into your charting software. So it's handy. But you can see there's a couple parameters that we will set. So we have the ability to do some quick sets here. This one's not set up because it's a training one, but you've got male or female on the top, okay? And then, you have your patient's height in inches. So what you'll do is, if we are 7 or 6 feet tall, we'll go to 72 inches. If we're 5'10", go to 70 inches. We'll set that based off the patient's height, because again, we are basing this off of ideal body weight, right? So the other 3 quick set guides that we have here on the right are going to be our percent minute while we're in a weird ASP. Yep, that's minute volume. We want to change that. But why you not allow me to change? Hello? Oh, that's not here. Like I said, we use PSIM-B or SIM-B for both. You can see on ours, it shows volume control. I'll come up here and get hands on. Volume control, we got SCMB and SIM-B, right? Those are the volume control settings we have. Then we have pressure control, PCB, PSIM-B, spontaneous breath, duopap, and APRV. Those are some critical care settings that we typically don't deal with in here. We will do the PSIM-B or the spontaneous ones, or SIM-B if we want to do volume. And then we have non-invasive, which will be your CPAP or your BiPAP, okay? So we're gonna put it in PSIM-B mode, hit confirm. That's where we want to be. And this will pop up. You can see there's a lot of different parameters on here that we can set. So we've got our P limit, which is our PP, right? That we will set to, I'm gonna go to 35, okay? So I have my rate, which I want to set to what? This is the injury patient, so I want to put where? Okay, flow trigger you'll leave alone. You can see down here, oxygen defaults to 50%. However, we're not hooked up to oxygen, so what are we gonna do?
Zero.
Drop it to 21. Okay. Our peak is at 5, and our peak inspiratory pressure, or PIP, is at 15. So what does that mean our combined P limit is then? 20, right, because they're additive values. So my additive value is 20, my P limit is 35, so I should be plenty. I could probably drop that down to 30 to be on the safe side, right? So if we want to, we can come in here and say, all right, I want my peak to be 10 and my peak to be 20. If I do that, then I'll have to change this back to 35. Just depends on where I want it to be. But once you do that, you hit confirm wherever you want your settings to be, right? Again, you can see it hasn't started. You do not start ours off the patient. So we're gonna be bagging right now. Too old for shit. So we're gonna be bagging, right? Good, of course, right? So we're bagging our patient, right? So what we're gonna do here is typically what we want to do is we want to take a pair of hemostats, connect this to save our PEEP. So when we block it, it keeps our PEEP in, because if not, our lungs deflate. All the work we've been doing, if we disconnect our ABM without taking a pair of hemostats, so we want to clamp them obviously before we let off to keep our PEEP in there, because if not, our lungs are going to deflate and all our alveolar collapse. And then when we put them on the vent, the first 10 ventilations are going to be getting that compliance up and getting all of that done. So we want to, we'll sit here and pre-oxygenate, we'll clamp our tube, and we will put our circuit on. And then we will hit start ventilation. Now, as you can see, on our graph here, starting to trend up, right? We're starting to gauge what we're doing. You'll notice that my VTEs over here are saying low. You'll notice that my minute volume is coming up. Now it was low and it was in the 200s and it's probably gonna drop down here. But we'll notice my VTEs are 295 and my minute volume is 4.8. Now, doing our math, if we said this was a whatever patient, we don't know, right? What can we do? We can come down here and it shows me right at the bottom of my values that my VTs for ideal body weight are 4. Where do I want those to be? Minimal. Remember, I'm asking for how many ml per key? 6 to 8. It's telling me I'm getting 4 and it's letting me know this is not going to work. So what am I gonna have to do? I'll have to go to my controls and do one of two things. Drop the heat down, right? And that can increase. And the things that, look at that, with 5 of peak, it gave me an extra 100 ml per breath. Because what is it allowing? It's allowing more breath to escape when it breathed off, meaning there's more room to expand. Now watch the lungs, right? Now here's the concerning part, right? If I bring this up to 15, watch what happens to the lungs. What's happening?
Hear the room air traffic.
Now what is it saying? I've got low VTE because I'm barely moving any air, and look at the barotrauma that I'm causing. So this is where, when, everybody's like, oh, it's, just a bunch of shit, it's not that concerning. 100% is. Look at the bottom of that lung. This monitor is not happy. Luckily, this one, you can see this is poking out in here. It should be. Everybody see that? Oh, yeah. Yeah, there. Okay. So low minute volume, low tidal volume, peak pressure, this thing is not in a happy state of mind. So watch, I dropped that. My VTEs are at 220. I dropped it back down to 5. Look at that. Instantly, I go up to 460, 480. Because I'm allowing more air to escape, meaning I have more air to build to get to that pressure. Now, on this graph up here, you can see my hard P limit line is that blue line going across this top graph. And that's saying my P limit is not being reached, so my settings are good. If we start getting close or past it, we've got a problem, right? Here it shows our flow staying at 5, and here it shows my waveform, okay? Now, the nice thing about this monitor, that makes it super fancy is I can use a dynamic lung graph. What this is measuring is my R inspiratory, my rinse, and my C set. You'll notice that I've got triangles in these lungs. So that means I don't have super great compliance just by looking at the picture, because they should be all shaded blue. That means I've got good compliance. And then also by looking at my C stat, it is 25. What is normal? 40 to 60 in your injury patients, 30 to 40 in your ARDS patients or your COPD patients. So this is telling me, hey, I'm having some compliance issues. Now, the reason I'm having compliance issues is this is fucking hard rub. I can't do anything about that. Hopefully Friday when we get these lungs in.
Everything that the entire male cell has lost shit and no below. And every time they sort on the road, and those shrink to your thing that the entire male cell lost shit and no below.
So this is nice again because I have a graph that shows me how is my lung, and this thing is accurate. Hopefully Friday I can show you how accurate that it is. when we start looking at these trapezoids that are in these lungs, you'll see those change if we can get a decent lungs, because we'll have full expansion and full elasticity. This is saying that, again, I've got bad compliance because they're fucking rubber and not tissue, right? But it's still giving me that, and my rinse is 12. So what does that mean? My normal is what? 10 to 15? So my rinse is good, my compliance is down because there is compliance issues because they don't fully expand. So again, now that I've changed these values up here, I can go to monitoring, I'm hitting 5.2, so I'm not quite there, but I'm close. So what can I do to achieve that to get it to 6, do we think? What do I change? I want to shoot for what? 6 to 8, right? What can I do to achieve my 6 to 8?
Drop your tube again, couldn't you?
I'm already at 5, so we don't want to go any lower.
Under minute volume.
So, but how do I adjust minute volume on? Do what? I don't have a minute volume control, so I can do one of two things. What? Change my rate, or tidal volume is based on pressure. Again, we're doing pressure delivery, not volume. Change my pip. So if I take my pip from 20 to 25, what did I just do? Dead nuts on the money at 6. So am I happy? 100%. Or something because we changed rate that much. Started at 5, we're at 5.2. And it's gonna sit there, now we're at 5.4. So easier thing to do because now we're hyperventilating. So I had to get to a rate of 22 to achieve that. Not super happy about that, right? So I'm more comfortable bringing that rate back down to where I want it to be and increasing my pip. Again, going back to here, I can sit here and make sure that I'm achieving my proper 6 ml per key of tidal volume. Does that make sense? You look lost. No, and I'm not being that shitty, I'm just, what can I explain? So the reason I like this vent, now, if you go to your work and you tell them to buy these vents, they're probably gonna laugh at you. These vents are about $32,000 a piece. So Jake and I might be able to afford it. Beyond that, oh, you guys will too. But beyond that, it's a hard stretch, it really is. However, these vents, in my opinion, are them and the Rebels are the best of them. I think, again, for the Rebel being the volume one, the Souls do their job, the AHPs do their job. The P Newtons, we've got one somewhere. It's 15 years old. That's the thing that I used back in the day. It looked like a boombox turn dial that you could adjust 4 things. Mandatory breath on and off, FiO2, 60 or 100, my rate, and my pressure. That's it. And you just hope for the best. Good luck. That's all you gotta do. Two toggle switches, 2 knobs.
I thought someone usually just would take them off the fence, drag it on, just get it easier.
Yeah, I mean, there's times that you be sitting there looking like a DJ doing a mix board at fucking Tomorrowland because you're just trying to dial shit in and it's not working. But vents have come a long way. Again, you can see I maintained like 6 ml per key based off my ideal body height that I put in here as, I think it was 68. So looking at your little sheet that I gave you, 70 inches is also known as what? 5'10", right? Yes. So 5'10" is going to equate to what? On that 440. Okay. So we got 440 times what's my rate? Down there. So what's that? 7,040. Right. What does my monitor tell me that my minute volume is? 7.1, also known as what? Pretty damn good. So, if we have oxygen, obviously, FiO2 is important. I usually start my people at 40 to 50% FiO2. That's where I start my people. You may have to adjust that to achieve your proper end-tidal or SpO2, depending on your patient. That is patient dependent. 40 is probably a good start. On these, the hose plugs into the side, and then you have a quick connect that you just screw on your oxygen bottle on the other side, on the high flow port, and you can sit here and adjust your FiO2 to whatever you want it to be, right? We don't, just everybody doesn't get 100% FiO2. We don't want to wash it, right? You're gonna have to adjust that FiO2 based off your patient's vital signs. Making sure there's not that BQ mismatch. Making sure that their end-tidal is a decent reading for them. For the situation, again, 35 to 45 is normal. But if we have people on the vent, they're not normal. So thinking that we're gonna achieve 35 to 45 on every patient is not our goal. Our goal is to know that they started at 78, we've got 52, we'll take it. Our goal is to understand that they were at 16 and now they're at 29, I'll take it. Okay? If we do RSI in the field and we innovate the field and we get Ross, we're gonna know what their end-tidal is because we would have got that reading when we first started, right? We should have that nasal cap no on, or we'll have that initial ET tube on when we're bagging, right? Same was my initial cap reading. Hey, do you have the turtle charger?
I never got one.
Okay. So we're gonna have that initial reading based off us if we do again, we need to go based off that. Now, if we had a patient that was if we have that patient that was breathing 30 minutes, right? And their initial end-tidal was 20, would it be fair to think that we can get them to 35? Sure, because their heart rate is fine. But we have to make sure they're not in that sepsis criteria. We have to make sure they're not in that cardiogenic shock criteria. We have to make sure they don't have that left-sided or right-sided shift, right? We need to make sure that they're adequate before we start trying to achieve certain goals. So that's why I said, do not try to chase numbers. Don't try to take a sick patient and make them perfect. That makes them worse. Okay? Don't take someone who is just shit in the bed and think that you're going to shoot for 100% oxygen saturation, a 35 end-tidal with a respiratory rate of 12. It's not going to happen. If you do, you're probably causing metabolic issues that are going to turn around and cause worse issues down the line. Okay? If you have the ability to do point-of-care testing, it's good to do when before, and it's good to do when right before you get somewhere so you know, hey, this is how I'm trending. Started a dog shit at less dog shit. Got one turd instead of 5. That's all. Make them better, not worse. So what I would do is I'd come up here. I would get used to the patient first, and I know we've all bagged one of these, but you can see how it feels. Bag and put one hand on the lungs and the other hand, on your bag so you can feel how that feels, see what that resistance is like, and then realize how hard and quick you're probably using a BBM. Honestly, most of us probably don't bag properly. These, again, I know we don't use these full-size bags here because a normal person's tidal volume is anywhere between 450 and 550, depending on female to male. This right here is 1500. there's no point. Okay. If you do have to use these big ones, I use the 2-finger technique and just squeeze like this over 2 seconds. And when you bag, I know some of you may know, but don't just let go. Let go, but provide resistance to the side of the bag. Because if not, you're causing that quick collapse, right? You want to push it in and help it out. Your goal here is to have, so when most people bag, you'll hear that like bagging, how the tone changes. You don't want that. You just want a steady sound the whole time. When you let out, you want to help it out. In and out, IE for bagging is the same. 2 in, 2 out. Okay. So do that and then set up your vent, move on. If you have any questions, please let me know. We'll be literally right here to help. But let's start that process. Again, make sure you set up your vent while someone else is bagging for you. And then make sure you do not start ventilation until they are hooked up to the ET tube.
You know, dirt.
So, you know. Better matter.
Do you have one of those,
Where'd she go?
Try to call and say about it.
okay. Do you have one of those?
Well, I thought I had it. That's getting here.
On the bookshelf.
If not, just grab my bag, I might be able to.
Okay, I like it.
And grab one off your truck, probably easier.
Good feeling.
So once you get one,
My oxygen supply failed, so I'm gonna have to adjust the toilet.
adjusted,
Yeah,
why is it going on? Now what's it say?
well, also external valve.
Hit the alarm button. So it shows an alarm. The one that's blinking, it's on the
Oh, yeah. There we go. That's good, right? That's a 6.
So hit your monitoring in the bottom left. And you also have an ASV mode.
Is that something I can adjust on the fly? That's what we're going, right?
You want peace in the. Just take the standard settings.
I mean, I'm learning it. I wanna see it like I'm on.
So this is the manometer I was talking about. You'll notice On here, it shows millimeters of mercury. It goes up. OP means overpressure. So when I do this, you can hear it, since this cup is now deflated. Watch what's going on with the BTEs.
Not happy.
It's barely more that's coming out of the mouth than there is the lungs. So with these, we'll push this in. You can see the number changing until we get to about 30. We can see here, maintaining about 30. So I'm good there. You'll notice, feel how not tight this balloon is. It's not as hard. Most of us go until it's super, right? Again, when we're dealing with Boyle's and Henry's law, when we're dealing with elevation changes, Boyle's law is going to say the higher the elevation goes, the less exerting force there is on the outside. So that means the more in that there is on the inside, because the force is no longer the same on the outside. So that's going to cause can cause that trauma. We just got in that syringe full, right? And then they go up 2,000, 3,000 feet. And now all that pressure, because the pressure's less, is now being pushed on their airway. Thank you, Lucas.
Nick, since I'm done, I already forgot, I'm wanting my minute volume to get up. What was like what did you adjust to make it go up without increasing my volume too much?
If your minute volume goes up, your tidal volume, right?
Yeah.
Or your rate goes up. So either you increase rate, so you have more of them being delivered. So take that to like 26. But now you'll notice you get less BTEs because the IE is no longer the same. So bring that back down to 16. So what else you can do, which would be take your inspiratory pressure, top right, bring that to about 23, 25. Okay, and take your peak up to, we call it 8 or 9. Now, see what just happened over, no, go back. See what just happened over here? Why is it yellow? Because what? It's not high. Why is it not high? 1, 4 plus 8 is what? 32. So this, because those have to bring this to at least 32. Okay? Now we can go down here, check our monitoring. It's showing us that we're at 7. Okay? Again, it's going to take a minute. We'll notice it's supposed to be R.
My pressure.
So we can go in. And then we'll start. I'll watch your B2. So down here, so let's say you want a 1 to, there's a 1 to 2. You'll notice these get shorter, this gets longer. Why? Because your inspiration. You'll notice your BTEs are. So I'm going to be patient.
he said it's open.
Now you'll notice I'm hitting my limit each time, so what's happening? Because stop. Well, that would be easier. But because why? What is this? What's the difference between those two? What's that called? Drop. A drop. Really? Still not gonna achieve my BTEs I want, but I'm in line. And then here I can take this back up to 25. 15 is the ideal driving pressure. You'll immediately start jumping up.
But really my BT should be like 400, shouldn't it? What am I doing wrong with not be achieving that? You said I'm chasing numbers and all, but
Super dance. I don't mind staying the same. Staying with it. And line. You know, 500 ml a minute. I could change you. Hey, didn't change either. I just gotta go back reading. Again, if you have someone that is Jeff. What's happening to that peak?
it's really doing.
Remember that big one? That's how you can see the path of his on.
I just like, shut this off.
You hit the power button once, put it in standby mode, and then hold the power button.
The next person. People think my brain's just. They don't learn all those. All really fresh.
Yeah, I think when you're studying, I think it's beneficial to come to here. Look at this. Sit here. Yes. Yeah. Ben Trainer. And then on top.
Yeah.
Simulator or Hamilton Benson.
Yeah.
That's just weird, that's way less than you.
That's an Hamilton. Stay on here. You go there, stay on
On that budget.
James Green, yeah, he's been paying all over.
Or, I'll definitely go.
Say Ben Trainer?
Yep. Got like a half of Olympics in the middle of the screen. Looks like what? Half of it. If you have an iPad, there's an app out there called Bench Trainer, but it's only one T. That you can simulate that bend on your iPad, play around with the settings and understand all the modes, PSIMV, SIMV, ASV, NSV, all of those things.
That's gangster.
That's,
That way I can fuck up a remote patient.
No, but seeing what the lungs do is still beneficial.
Get it in charger, Jackie?
I did. It's clean, just like,
$60 right there.
they want, not $180.
Is it free? Could be. What's $180?
Oh, we're talking about Jackie's.
I've broken 3 of them, so I've spent $880 on these chargers from the top.
There is also an app that will make your life 100% easier. However, it does cost money. It's called Easy Resus. EZRESUS. It's like $40 or $50 a year. So you might not do it now, but if anybody wants to look at it, I've got it on my phone. And what you can do,
Does it look like a blood drop?
yes. So what you can do is when you go to Easy Resus, it brings you this up. I can click my patient, it's adult, kilos, so 277 pounds, their height is foot, right? I can hit here, it brings me up every medication dosage that I want. Go to, I can say, hey, I want 10 mics a minute,
That's on.
and it brings me 28.2 ml an hour. B, also, you can go to intubation checklist and what you might need. You can go to innovation checklist, resuscitation, what my respiratory rate needs to be, what my vent settings need to be, what my lidocaine dosages, my amnio dosages, my epi dosages. All of these.
Pediatric, one of those two, like, these.
Well, yeah, there's also, once you download this one, you can pick pediatric or neonate off this one as well. So again, it's like 50 or 60 bucks, but makes your life easier.
So what's that other, dosage calculator that you wanna tell us about? We got to,
There's a bunch, there's
it's like critical something.
rate, critical calc, I think, and there's quite a few out there.
And half of the white sea in it.
Yeah, critical costs like $15. I have them right here. The block of cheese, and then critical is like, it's only one payment of $15.
Pocket fees, I think it's still subscription based, either monthly or yearly.
Yeah,
That's why I like the easy resus. I mean, I think part of it is, if you get the full the full thing, it's not.
Yeah.
Um, and then, like I said, the easy resus, I think it's 50 or 60 bucks, but it's yearly, but it breaks down to, $5 a month or something, so it's not that bad of a deal.
So someone asked me a question the other day, and I meant to ask you about it.
Mm-hmm.
Someone asked if I had pre-licensure insurance. And I didn't know that that's a thing. I guess there's like